let's give a warm Pachyderm Club welcome to Ashley Lunkenheimer.
Good afternoon, everyone. Thank you so much for having me here today. I'm very honored to have the opportunity to talk to you all today. Healthcare is something that is so important in our current times, and especially in our community as we're facing nursing shortages and staffing challenges. And so I really wanted to be thoughtful about what we talked about today. And I wanted to talk to you about the way in which the Veterans Affairs has prioritized healthcare and how we can translate that to the private sector, to our communities, to improve care. If you're a veteran, would you mind raising your hand for me, please? Thank you so much for your service. So this is really important for our veterans. They deserve this great care that we want to provide them. They have chosen to give their lives so that we can be here today and speak freely, a luxury that is not afforded in other parts of the world, as you all know, especially as of late. For those of us who are not veterans, my dad is a veteran, I am not a veteran, I can't choose the Dole V.A. to get care for myself. And so or for my husband, who's a police officer and at risk every day, or for my little children. And so it's really important to me that the lessons that we've learned to provide exceptional health care in the VA, that we translate that into the private sector. So I'm going to talk to you a little bit about that today. So I think it's really important to talk about what our mission, vision, and values are at the VA. How do we focus the care that we provide and make sure that we're always on track with that care? So our goal is to care for those who shall have borne the battle and for their families, caregivers, and survivors, lead the future in delivering unparalleled health and well-being to our nation's veterans and to the nation. So something really interesting about this, if you don't know, we have expanded our healthcare coverage some to not just veterans, to some caregivers and survivors dependent upon benefits. And then we also expanded our care during COVID to the fourth mission. The fourth mission of the VHA is to serve our humanitarians. So we've had several situations like that with FEMA disasters, like in Louisiana with Hurricane Katrina, and most recently with COVID, where our city hospitals, Wesley and VIA, were completely full, unable to accept any more patients. We took humanitarians in that had never served as veterans and provided them health care. So that's something recently that we've been able to expand and provide that care. There are 6 strategic priorities for VHA, and I'm going to walk you through each of them. And I think it's important. I was talking to my husband about this last night, and I'm like, I hope my presentation isn't dry. I don't want it to feel dry, but I want to explain to you and share with you why each of these is so important, because it's not just important for the VHA, it's important for healthcare as a whole. And we've got to do better in Wichita and Kansas and really being committed to this healthcare and keeping these good clinicians here so that we can continue to keep good care in Kansas. So those 6 priorities set by Dr. Sharif El-Nahal, he is the leader of VHA, is to hire faster and more competitively, connect veterans with the soonest and best care, serve veterans with military exposures. I'll share a little bit more about that. Accelerate our journey to a high reliability organization, support veterans' whole health, caregivers, and other supporters, and prevent veteran suicide, which I think is, to me, the most important. So to start with hire faster and more competitively, this is really important for Wichita. You may have heard it's hard to get on to the VA, and actually on my way here I was on an interview, and on my way back I will be on an interview to get folks here. And we do that because we're so committed to this, because our veterans, our population deserves the very best care. And so our hiring process is extraordinarily thorough. There's background checks, there are reference checks. If you come to the VA, you can be rest assured that the person providing your care has been thoroughly vetted to make sure that they are exceptional. There's challenges in the Wichita market, and I want to talk to you a little bit about that, because these impact our other facilities much more than they impact the VHA. You may have heard on the news during COVID about us being out of beds, or there not being enough beds in the community. That's true in a sense, but really there are physical beds, there are physical rooms, there are no nurses to care for those patients. And so while we could admit we couldn't because there were no nurses, not at the VHA, but at other facilities, we didn't have that problem at the VA. And I want to talk to you about why I don't think we had that problem and how we can do things differently everywhere to make sure that people can choose to stay in Wichita versus being transported out. So there is travel opportunities. I get probably 5 or 6 text messages a day from travel agencies asking me to come travel to New York and California, who will pay an extraordinary amount of money for me to go be a travel nurse there. Every nurse in this community is getting the same requests. And so if you're 22 and single and don't have little children like I do, that is very tempting to go make $100 an hour in California for 3 months. Pay is a challenge. We're one of the lowest paying markets in Wichita for healthcare nationally. And we have a different market now. So and by market, I mean a different market of employees. Historically, you had employees that would stay at a job for 60 years. They would retire there. They would work there for, their whole careers. Now you have a set of millennials or Gen Zs or I don't know what we call them anymore, but who are very interested in flexibility and that ability to be present in their real lives and with their families, and so scheduling can be challenging. The other piece is ratios. So evidence-based practice is established through research, and it shows us that the amount of patients we have per nurse matters. It affects quality, it affects outcomes, it affects mortality and morbidity. In a medical surgical unit, the best practice is to have ratios no more than 1 to 6. That means 1 nurse for 6 patients, less if you have very high acute patients, sometimes more if very low, but that should be rare. At the VA, we keep our ratios at 1 to 5, never ever more than that, often less, 1 to 4, 1 to 3 at times, because you can provide that whole health care a little bit better. That costs money, though. That costs money to do that. And it has to be a commitment that's where you prioritize your funding. And that brings to the last item on this slide. So hiring the right people, you have to hire people with your focus of quality over profit. Every nonprofit, for-profit, government, there's always a bottom line, right? We all have a budget we have to maintain, and we as VHA have to be good stewards of our resources. Even though we don't make money, we certainly cannot abuse or misuse money. We're very committed to using that money appropriately. But the focus of everything we have to do has to be on the quality of our patients, and that can never be cut for finance or for profit. And so that's really important to us at the VHA. The next is to connect our veterans to the soonest and best care. We use several tools to make sure that we're doing this and that our veterans can choose us if they want. A couple things to note. I'm super excited. This is the first time this has been publicly announced, so you guys get in on the news before even the news knows, unless any of you are from the news. But the Robert J. Dole V.A. has just been upgraded to a level 1 facility. That is a huge deal. So in the VA, there are 3 levels, 1, 2, 3. 1 is the highest, most complex, offers the most to our veterans, pulls in the most veterans we can from our catchment area, has invasive procedures, and really can care for our veterans holistically and completely. A level 3 facility might be like a rural facility that doesn't have a lot of accesses. We've been a level 2 facility for 6 years. Because of our commitment to bring in some specialty providers and really listen to what our veterans have to say, we've been upgraded as of yesterday to a level 1 facility. So thank you. We're super excited about that, and thank you. And I think it really shows our commitment to our community. We don't want you to have to leave Wichita to get great care. And so we're really excited about that. The other piece is there is a white paper recently published, and I can share with Jennifer to send out later. But one of the things we're focused on really is research. And there was a research article recently published by Dr. David Chan, really measuring the quality of care for veterans who choose the VA for their care versus those who choose another hospital. Those who choose the VA for their emergency department care and admission have a lower chance of mortality and morbidity, meaning they're less likely to die or have serious complications if they choose the VA, largely in part of our commitment to quality and those ratios. So we want to make sure we're providing the best care possible. Some really new exciting acts have been passed, and this is important for legislation and why I'm so thankful for this club and your support of VHA and our veterans, because I think it goes to show how that support can make a difference in healthcare, not only in the government sector, but in the private as well. We've had a few new laws passed in the last year that have dramatically improved the way that we can provide care to our veterans. I'm going to walk you through a couple of those. The first is the PACT Act. So this expands VA coverage to mostly veterans who are after Operation Iraqi Freedom, after 9/11. When I worked at the VA 10 years ago, so I started at the VA in 2013, and I left and went to a private hospital. I was recruited there, but I left because I transparently did not feel like we had the quality that I wanted to be a part of. And I told you my dad's a veteran, and he did not and would not choose the VA for his care at that time. I was recruited back in 2019 and have been there since. And we are seeing our population of veterans age decrease. So we used to never see women. We used to never see those in their 30s or 40s. We're seeing that all the time now. And our care is so much better. I was telling some folks when I walked in, I anecdotally measure quality based on how much my dad will choose to come to the VA. So he now will see us for primary care. He goes to PT with us. He's having surgery with us. And so to me, that means so much, because each of these data points I'm going to walk you through in my heart is my dad, or is a veteran, is somebody's dad. And I want us to know for sure that we're providing great care to them and that they can trust us to provide great care and choose us. So the PACT Act expanded some coverage. It also added 20 more presumptive conditions and exposure locations. It also requires us to perform a toxic exposure screening on 100% of people that come to the VA to make sure if they could have potentially qualified for this, that we can qualify them for more services. This slide is kind of didn't come across quite right, so I'll walk you through that. The Compact Act was a very exciting expansion for us. This expanded care for veterans who have served at least 24 months or had any act of assault while in the military, whether that was physical or military sexual trauma. But it provides suicidal coverage to any person who comes to the VA in a suicidal crisis. So if they have served greater than 24 months or they had any of those conditions, not only will we provide their emergency department care, we'll provide up to 30 days of residential care and 90 days of outpatient care. Additionally, any person who is not a veteran who comes to the emergency department will receive a medical screening exam and emergency care. Suicide is something we take super seriously. If someone trusts us enough to tell us that they're struggling, we are going to take it seriously and give them the support. So I was very excited to see this passed, thanks in part to our legislative our partners in Senator Marshall's office and many others who helped get this passed. So thank you for that. Our next is a high reliability organization. So what this means, it's a bunch of fancy words, and I have the high reliability team that reports to me at the VA, and I tell them to stop using such fancy terms because no one knows what they're talking about. But essentially, this is making sure that we move to a place of zero harm. Our goal is to model ourselves after the airline industry. So if you can imagine, this ideation started in the airline industry when we were having commercial jets crash all the time, and accidents happen all the time, and one accident was too many because there was human lives lost. And so they developed things like checklist, a safe space to report concerns. You can share if you're worried about something, even if it hasn't happened, so that we can address things timely. We know that a high reliable organization has less accidents, less incidents that happen. We're human. We want to prevent 100% of things that happen, and the way that we do that is by having this type of organization. As of last year, we had over 93% of staff nationally that have been trained on these principles. And I'm gonna, oh golly, that went a little bit too far. I'm gonna walk you through what some of those are. These are the 5 super fancy terms that I tell my people to stop using. But essentially, they're just asking questions of, are we making sure that we're thinking about what's the worst thing that could happen? Instead of thinking, it'll be fine. What is the worst thing that can happen, and how can we prepare for that? If we're going to take a 98-year-old World War II veteran to the cath lab, what is the worst thing that can happen, and how can we make sure that it doesn't? How can we make sure that we're looking at close calls, that we're committed to improving care, and that we're really using deference to expertise? This is something that's very different for me in the VHA than the private sector. When we make decisions, we pull in all the key players. So this isn't a CEO saying, hey, I think we should, close down med surge and open up a bigger ICU because we get more money that way. This is, let's bring in the chief of cardiology, the chief of, wherever, to give us the expertise to make sure we're making good decisions with quality as a forefront, not budget. The next is really supporting veterans' whole health, their caregivers and survivors. I talked a little bit about the way that we're doing that. One thing we're really committed to right now is the homelessness. You all probably have noticed an increase in homelessness, not only in our community, but if you've traveled. I just recently was at a conference in Denver, and I was shocked. I haven't been there in 5 or 6 years. And my Uber driver, we were going from the airport to my hotel, and there was lines and lines of tents. And I just had never seen, I was just shocked. And I asked my Uber driver, and he said, oh, it's much better than it was a couple years ago. And I'm like, I just can't imagine that being better. And it makes me so sad and sick. There was recently a study done of our homeless population in Wichita. About 80% of them have some sort of mental health condition that they could use support for. So one thing we're really focused on right now is homeless program outreach. We just did a big outreach event at a park where we were able to provide clothing and haircuts and job applications and even pet care for the pets that they had. And I think that's something that's really special with the VA and different from the private sector. We're connected. So if you go to the VA ER, we also know who your primary care doctor is, and we know your diagnoses, we know what medications you're on, we know what military trauma you've had, so we can be careful. That's connected. We can also create immediate follow-up appointments for you that we can't do in the private sector. We can make sure that you have a PT follow-up. We can send PT to your house to make sure your stairs are safe when you go up and down them so that you don't fall when you go home. So that interconnection and that whole health approach is very important to us, and I think something that we really should focus on, how do we translate that to the community? We have patients who aren't veterans who come to our local ERs constantly for care, and how do we connect them with primary care and make sure that they're living in safe situations and get them those social services? And it's hard, it's a mountain to climb, but VHA has done it through its interconnectedness, and it would be my dream come true that we can model that in the private sector as well and make sure that our citizens get safe and effective care in Wichita. The last and most important, to me at least, is suicide. And I want to tell you a story of why this is so important, because I think connecting is really important when you're talking to folks about your priorities. So I mentioned that my husband is a cop, and I meant to marry rich, but that is not the way. So let me tell you, I'll be working every day the rest of my life. But he's a hero for sure. And one of the police officers that worked alongside him was a veteran and really struggling with some PTSD. He was very close to my husband. He'd been to our house. We really cared about him. And we were at a movie last year, and our phones were just blowing up. And so we stepped out, and that officer had committed suicide. And it was devastating. And he had a little boy, and he just felt like the stress of the military and then now policing. If you have read the news anytime recently, it's not the funnest time to be a cop right now. It was too much, and we lost him. And it was devastating because I think certainly for my husband, even for myself as a tertiary person affected by this, for my whole life will think, gosh, what could we have done? What could we have noticed? Should we have invited him to dinner one more time? And we know our veterans struggle with this, so this is a priority for us. We know our veterans that are a higher risk for suicide. Women are 2 times more likely to commit suicide if they're a veteran than if they're not, 1.3 times if they're a male, and one suicide impacts an average of 135 people. And that feeling that we have forever, I don't want anyone to have that feeling. And so I share this story often with clinicians in our new employee orientation of why it matters. You don't ever want to be the last person that saw or treated somebody before oh gosh, that scared me, before they commit suicide. You want to be that person that helps. And unfortunately, suicide is a real thing in the VA. We see it too often. One time is too often. And so we are super, super committed to turning that around and giving them support. The way that we're doing that is screening our veterans. We have an evidence-based tool called the CSSRS. We love acronyms in the VA, but we essentially ask a whole bunch of questions to every single veteran that presents to our ED every single time they come to our ED. Most folks who have committed, who have plans to commit suicide or do have a successful completion, 90% of them have had an ED visit within the last 60 days. And so we really want to capture those folks. We also provide every single veteran of a suicide screening once per year, whether that's if they don't go to the ED. So if they go to primary care or specialty care, whatever, we're going to screen them. If they screen positive for suicide, they immediately get a one-to-one sitter. That's different than the private sector, where we have somebody who sits beside them within arm's reach the entire time they're with us. We do not leave them. We are with them. They do not have to walk that journey alone. And we create a safety plan for them. Sometimes they have to be admitted. Most times they are admitted so we can get them the treatment they need. Sometimes not. Sometimes we can create a safety plan for them where they can go home, but we have very intensive outpatient treatment and therapy for them. So we're super committed to that, and I think it goes to show how much resources we pour into that. It's not cheap to have somebody sit with somebody 24 hours a day while they're with us, but no amount is too much. It's the right thing to do, and that's our focus. So here are our priorities, some strategic enablers. These are some other things that we're focusing on, like modernizing our future and really focusing on research and innovation. The Dole V.A. has grown from 1 research study last year. Now we are a part of 7 research studies. We really want to be on the cutting edge of trends and making sure that we're providing the quickest, best care to our veterans. One good example of that is tele-emergency care. And if you're not an emergency room person, you might think to yourself, how can you get emergency care at home? Most emergency care is, I have a toothache, or I have a rash I'm not sure about, or my tummy feels kind of sick. Not necessarily that I'm having a heart attack or stroke. Obviously, you'd have to come in. But for those cases, we have the ability to video conference in with our veterans, with a provider, with a doctor, and a board-certified ED doctor, and walk them through so they never even have to leave their homes. And we can make sure to get them that care. That's really important for our rural veterans. We know we have people in Goodland, Kansas, that their closest hospital is in Denver, and we want to make sure that they can get treatment quickly. I mentioned we're really focused on quality. One of those ways that we focus is something called SAIL, Strategic Analytic for Improvement Learning. I won't go into this because it's kind of boring, but it's my job to monitor this and be very focused in on this. We rank ourselves not only against other VAs, but against ourselves. Good is never good enough for us. We are ranked in 5 quintiles, so top 20%, bottom 20%, somewhere in between. We have 0 of our categories in the bottom 20% of the country. Everything is above that. That's very rare. We have in the region, we're the only ones that have that in all of the VA within our region in Missouri, Illinois. And it's because we're so focused. But, if you know me, those orange 4th quintile really bother me. And I don't want to have any 4th quintile. I want to have 1st and 2nd. I want to be better, and I want our teams to want that. And so this is the message that we send. Like, I'm so glad we don't have 5th quintile. What are we doing to fix these 4th? And some of those 4th are things like flu shots, which we have some vaccine hesitancy with all the COVID things. But other things are care coordination, making sure when our patients leave our hospital that they're getting good care coordination. And so the interview I was on the way here was hiring a person for that, because I'm not going to have us be in 4th quintile. So that's one way we measure. I wanted to share this. This is another way that we measure healthcare. It's actually CMS that measures this, and every hospital, you can look this up on your own anytime, Hospital Compare. They rate facilities. You can choose any facilities in the area. I chose Dole V.A. just because because those are the big ones. Wesley and Wichita, Dole V.A., we're the only 5-star facilities in the region. Everyone else is 3 or 4 or less. Those are measures based on mortality. Are we taking care of people? Are we making sure to treat their diagnosis? Do we have complications after surgery? Are we reducing infections? And then patient survey, we have the highest rating at the Dole V.A. Of any hospital in the area as a 4-star rating, meaning our patients feel like we do a great job. So we're looking at a multitude of modalities to make sure that quality care is exceptional. So what's next for VHA? Some top focus items for us are suicide prevention and geriatrics. That's always going to be what we're best at. What we're focused on at the Dole V.A., we have a brand new medical center director, which is like our CEO. I adore him. I think he's fantastic. It really bothers him anytime we can't keep someone at the Dole V.A. We have to divert them to another facility. It bothers me. I hate that. And so we're very committed to our catchment area, which is all the veterans within our network, being able to bring them into the VA and allow them to have that choice. Veterans' choice is important. I want my dad to not choose us if he doesn't feel comfortable with that. I want him to have that choice, but I want to earn his trust, and if he wants to come to us, I want him to have that opportunity. Same with all VHA veterans. And then lastly, really tying this back to Wichita community healthcare. How do we emulate some of these things that the VA has done in our community? And I want you to know that I'm a Wichita Derby girl first and a VA employee second. And I want my kids to be able to choose great care here. I want my husband and his colleagues, God forbid there ever be a situation again with a police officer, I want them to get great care. And I believe that we have great clinicians. I've worked at Wesley for a decade, and there are great nurses and trauma docs, most of who I've recruited to the VA, but there's still lots of great ones there. But I want them to be able to choose great care. And so I think the way that we do that is focus on quality. You'll never find a doctor or a nurse who cares about making a hospital more money. You will not find that. You will find doctors and nurses who care about great outcomes, about serving their patients, about making a difference, about saving lives. And so when we focus on that, you attract the right talent. I think we need to incentivize hard positions. We pay one of the lowest in the country, and we have lower cost of living. So that makes sense in a lot of ways. But when we know our 22-year-old nurses can go to New York City for the winter and make $100 an hour, they're going to do that. So how do we incentivize them to stay and develop a mentorship? I want to connect with as many young nurses as I can and make them aware of how great of a community we have, how supported we are by clubs like yours and by legislation like we have in the room. And then lastly, and most importantly, is patience over everything. I've said this probably 7 times in this presentation. Nothing should matter more than our patients. And every data point on that sale radar I showed you is my dad, is someone's dad, is many of you in this room. And when we can translate our thought from how do we make money in healthcare to how do we save lives and make a difference in healthcare, that's the secret sauce. That's how we connect. And so I'm super honored to have the opportunity to talk to you all today. I know that's a lot of data, but I hope you leave with a sense of passion and urgency and excitement around what we can do for healthcare in Wichita and how we can make it a better place to receive care and to grow old and to have babies and really improve the way our citizens are treated and receive care here. So thank you so much for your time. I can open it up to any questions as well.
Thank you for coming, Chairman.
Thank you.
2 questions. One is, how is the VA related to the U.S. healthcare service? And the other question is, I know for a while there was a way that veterans could get served at local clinics because they couldn't travel or it was tough to cover. Is that still in place, and how's that?
Yeah, absolutely. I can answer both of those. So VHA is a subsidy of VA, which has the Veteran Benefits Affairs and then also the Veteran Cemetery, and VHA is the healthcare portion. The U.S. government healthcare system is totally separate, and it's for civilians, although veterans can access that for some supplemental insurance options. For our veterans, it depends on the level of service connection how much is covered for the VA. So for example, if you're 100% service-connected veteran, you receive all care. If you're 60%, it's a little bit different. But what has happened is the expansion of some of those acts. So we are trying to get everyone as much service connection as we possibly can so that you can rely on VA. So that's some of the toxic exposure screens and things. The second question around community-based, thank you so much for bringing that up. So that's a really important facet that we have with how much rural healthcare we have. So we have the big Dole V.A. here. We have 6 CBOCs, the acronyms, we just love them, community-based outpatient centers. These centers have primary care doctors, nurses, lab, some have radiology, so that you don't have to travel to Wichita to get your care. You can receive that in your community. We have those at Hayes, Hutch, Salina, Parsons, Great Bend. I'm forgetting one really important one, I'm sure, but really around the area. We constantly do catchment area surveys to see, do we need to expand this clinic? Do we need to close this one and make a bigger one here? We don't like to close because we want people to be able to choose us without having to travel far. One way that we've addressed when there isn't a lot of veterans in that area is we have a mobile clinic, which is like a big bus with a doctor and a nurse and all you can need for a visit that goes to those sites. So Great Bend is one that we send a bus out to get them care. We also have veteran transportation services where we can go get veterans and bring them to the Dole V.A. if they're having surgeries or procedures or things. But yes, that's another great resource that we offer and helps keep us connected throughout Kansas versus them having to choose a primary care clinic not connected within VHI. Thank you for that question. Questions?
Thank you very much for the excellent talk.
Thank you.
I was thinking of asking you about homeless veterans. There are many people not in the hospital, but they're homeless people. Mm-hmm. Do you provide a treatment for those people?
We do. Yes, we do. Thank you so much for that question. We are very committed to homeless veterans. So a few things we do. We have a homeless outreach team, and I'm not sure if it's quarterly or monthly, but at least quarterly, we physically go out and find homeless veterans and citizens. So you'd be surprised, behind Botanica, there's this big grassy field. There are a lot of people living there, and a lot of them are veterans. And so we go out to get a count, see what resources they need. We also have a clinical team, kind of like the ICT street team that they're doing for non-VA citizens, where we can go out and provide care on the street. So if they need wound care, they need medications, they need a box of meds, they need a weekly Invega shot, which is a way to deal with schizophrenia, we can provide that. We also connect them, and this is what's a little bit different outside of healthcare, whole health. So how can we help you get a haircut, get you clothes, get you an interview, get you into therapy? We additionally have a new program called our DOM-SUD. This is an inpatient substance abuse facility located on the Dole V.A. Campus. Many of our homeless veterans have substance abuse issues as a part of their mental health diagnosis. It's kind of hard to know what came first, the chicken or the egg, but often folks have both. And so if we can get them to agree to go into our DOM-SUD program, this is a 3-week intensive program to assist them with reducing that substance dependency or eliminating, which is the goal, so that they can lead more productive lives, and we can transition them into things like a group home and get them jobs as well. Thank you for that question. Yeah.
Hi, Ashlyn. Hi. Great talk. Thank you for serving at our local VA.
Thank you.
Addressing one of your slides on quality of care, I've seen this slippery slope not only in hospitals, but especially in the nursing homes, where another has recently been, and that is this term nurse. So I see licensed practical nurses, LPNs, doing what RNs and ASNs should be doing and making some terrible mistakes. Is any of this even being addressed? So I see that term nurse really deteriorating.
Thank you for that. So I think it's 2 parts. You're right. Nurse has become a licensed practice nurse and CNA and not RN necessarily. the state of Kansas is very prescriptive on scope of who can do what. At the VA, we're very committed to allowing folks to work at the top of their scope, not over, but at the top. We want to utilize folks to their full potential. We don't really have many LPNs, although we do have some, and where we do have them is in less acute places like our community living center, our rehab, some of our primary care clinics. There's a place for LPNs, and they're brilliant in what they do, but we do have to be careful. I think some of what I've noticed as well is that with our lack of ability to keep and retain RNs, we've expanded our pool into LPNs, and I think it's a Band-Aid. I really think it's a Band-Aid to fix a big problem. You need registered nurses to provide that level of care. LPNs can't provide, they cannot do assessments, they can only do observations. There's several medications that they can't give. There's lots of procedures that they cannot do, and there is a place for them. They're so valuable. I don't want to lose sight of that. But the solution of a low RN workforce is not to supplement it with a lower licensure. We have to be creative and figure out ways that we can support our nurses and keep them in the community. How we do that at the Dole V.A. is we have that very specific scope that we follow. We have our national standards which supersede state, but we also really are focused on mentoring retention. Our turnover rate or vacancy rate at the Dole V.A. hovers around 3% for nurses. In the community, it's 50 to 75%. So we have to figure out ways to engage them, let them have a voice, let them be a part of decisions, respect ratios, make quality a top proponent. And I think that's important. I think that comparison is important because I didn't do that. I didn't make our percentage 3%. Our leaders and our commitment did that. And I think that stark difference is important because those nurses that work at the VHA live in the exact same neighborhoods as the nurses that live everywhere else. So they're choosing to stay for a reason. And I think we have to honor those reasons, hear those voices, respect that profession. And it can be done in Wichita. And I want it to be done because I want us to have good clinicians at the bedside when all of you and me and our families have to go in for health care. Thank you for that question.
Hi, thanks for being here again. Can you discuss the recent article in the Wichita Business Journal about the VA regional office relocating?
Yeah.
Did it have any effect elevating from level 2 to level 3 at the hospital?
That's a great question. So space is hard at the VA. If you've been to the VA, you know it's a historical site and it's beautiful. But there are challenges with historical sites. You can't just knock down a wall. You can't just build on. It's a whole thing. So I'm sure you all know about that. So for us, we really wanted to prioritize our Dole main campus VA for clinical spaces. We didn't want to limit what we could provide our veterans by having administrative workforces in that space. So we've made some decisions in collaboration with folks at the VBA and other offices of how can we still serve veterans and make sure that we're using our space and our resources in a fiscally responsible and ethically responsible way. So it had nothing to do with the upgrade of a level 2 to a 1. It was way in the works before that, but it was really just being strategic around the space that we have. We don't want our veterans to not be able to use VBA though when they come and see us, because a lot of times they come to the VA and they have benefit questions. So we've mitigated that some by having a large office space that's now dedicated to our veteran experience officers, and then representatives from our veteran service organizations like the VFW, the Paralyzed Veterans Organization, so that they have at least one of those resources on site that they can reach out to, even if the whole VBA isn't there any longer. Another reason for that change is VHA is going through a modernization of our technology. So we have this super antiquated electronic medical record called CPRS, and it really does look like Microsoft Word's first DOS version. So old and difficult to connect. So we're moving to Cerner, which is what Via Christi uses as their healthcare model, and they've had great success. It's used throughout the country, Johns Hopkins, et cetera. Part of that was we had to have spaces for the EHR upgrade to make sure we can make that. So space is so hard. It's always a challenge. Right now, I share an office with somebody. One of my people that report to me, there's 6 people in one room because I am not clinically forward-facing. I don't need a space to myself. I need whatever space would be given to myself to veteran forward-facing care. And so sometimes we have to make those decisions. It's awkward when you're sharing an office with people or you have to make some moves, but we really want to prioritize our space for direct-facing care. So that's why those decisions were made. I hope that helps. Yeah.
Hi, Ashley. I just wanted to let you know, we have a gentleman in our church who recently, well, a year ago, was diagnosed with ALS. And he really sings the praises of the VA hospital here because he just knew back in Connecticut he would never have gotten the services. The van, the chair, everything that goes with it. So just wanted to let you know that he sings your praises on a regular basis.
Thank you. I know that veteran, and I know almost all the veterans that come to our inpatient care because I hear their stories, and I know how hard that was for him and his family and his son and how we walked through that. That's not unique. My husband's grandfather is a veteran. He was recently admitted, and he really struggled with mobility. And even though I work at the VA, I make a joke that every week I find out about a new program that we offer that I didn't know existed before. He had PT come out and they remodeled his shower because it was a step-in shower and that was too hard for him. VA covered a shower remodel, put in grab bars up and down the stairs. They put in a chair lift up the stairs for him. They have someone coming to help him give a bath 3 times a week. They have nursing coming in. Just exceptional whole integrated health so that when you come to the VA, your care doesn't stop. We want you to be as independent successfully as long as you want. So thanks for sharing that. That was a very special veteran. ALS is such a horrible, terrible thief of a disease, and it was truly, truly an honor to help walk them through that really hard time. And it wasn't me, it was my teams, but I know that veteran well. So thank you for sharing that.
Thank you for being here.
Of course. I can hear you. Yeah.
A couple of questions. When President Trump was president, he made a number of changes to the VA. One of those, incompetent people can be fired.
Yeah.
Is that still true?
Yeah. It's a little different now, and I can talk more about that, yes.
I want to know also about the waiting time, a lot less. If
Yes.
someone needs a new hip, how long does it take to get a new hip? Last but not least, on my own account, I went to the VA 15, 16 years ago to make an application to get into the pharmacy there. And they gave me a booklet like 30 some odd pages. I don't remember exactly how much. And every page had questions on it. And I just blew it off. Is it still that hard to make an application to get services from the VA?
Yeah, let me answer all those for you. Thank you. Those are such good questions. So we are a government agency. So just like any government agency, anytime there's a new president or new leaders, there is a pendulum swing. And sometimes it's very dramatic and sometimes not. This was very dramatic. President Trump did put into some protections that were a little bit different than previous presidents like President Obama or President Biden, in which unions didn't have as much control and involvement in the decisions we made as leaders. So when I worked here in 2013, union was a very big problem. It was very difficult to fire anybody, to determine somebody was incompetent and move them on was literally an act of Congress. When President Trump came, that changed. We were able to hire very quickly. We didn't have to go through all the rigmarole that we had before, and we were able to make some of those firing decisions quickly. I think there's a balance in everything, right? You want to make sure that you're hiring the right people and doing a good job of that, but you also want to be able to make decisions when you have made a wrong decision and hired the wrong person, get them away from veteran care as quickly as possible. So while we aren't at the place we are with Donald Trump, it is much improved than we were in 2013. We have a very specific process we follow to take concerns seriously, one of which is that anytime there's an investigation about inappropriate care or not exceptional care, there's a peer review process that I'm a part of. That person is removed from clinical service until we can ensure that they're safe, and then we make next steps. So it isn't what it was in 2013. It's much, much improved. We also have a very good relationship with our union, and you all have probably heard a lot about healthcare and union in the press lately. Via Christi just got their union. And there's a place for everything. If you have good relationships with your employees and they feel like they have a voice and they feel like they are heard and respected, you really don't need a union because you have that relationship. If you don't have that, you might need a union. And so right now what we do have a union. All VHAs do. Some have more than one. Our union relationship is really great because our union partners know that we respect our clinicians. We were just today actually accepted a national recognition. We're only one of 11 VAs in the country that have been recognized as a Pathway to Excellence facility, meaning that our nurses rated us as an exceptional place to work. Only one of 3 in Kansas. So we work well with them, and we can make those decisions as we need to. As far as the application process to get services, much easier now than it was 15, 16 years ago. And the reason for that are some of these expanded acts that our legislation has made possible. So now if you were potentially exposed to Agent Orange in this potential location, you'll get services. There's other conditions that you'll automatically get services for regardless before we can validate. We also have a new U.S. code, new-ish. It's 1784A, and basically it is our protection that if anyone comes to us for care, we will offer them a medical screening exam and make sure that they're stable, veteran or non-veteran, 2 years old or 102 years old. So it's much easier and simplified now. And then the last thing about the wait times. So wait times were a big thing for VHA. Phoenix got into some hot water several years ago when they were found to have wait lists and all kinds of things for people to get appointments. That is highly regulated and monitored now because we don't want any special treatment. So what we have now in every facility is something called a general practice manager. They measure from the time you request an appointment to the time you're called, to the time you're in the door. And those measures are reported every single day to our executive leadership team, which is reported to the VISN, and then we have to report that to all of our congressmen and senators as well. So that is something that we're super focused on because we never want anything like that to happen again. We also measure ourselves against each other. So if there are areas within our VHA that takes a little bit longer to get into, we're looking at, can we add an additional provider? Can we expand their hours? Can we borrow a provider from a different facility to get those seen because we need to bring that average down? That's reviewed every single day by executive leadership team, which I'm a part of. So we are in a much better place. I trust the care. I wouldn't work there if I didn't, and I've left when I hadn't. We're in a much better place for those things. Thank you for asking that, and I hope we can gain your trust again one day.
We get the last question over here. We got to wrap it up.
Yes, sir.
Thank you for your presentation. This has been very enlightening.
Thank you.
We're very pleased that you've made the strides that you have.
Thank you.
I think it was almost a disaster before. But the name of the facility, Robert Dole, and that means a lot to the people in Kansas and the people who have met him. What do you guys take pride in that? Do you move extra effort? Do you think, oh, I got to do what would be honoring his memory?
Oh, that's such a special question. Thank you for that. I was a little girl when they named that facility Robert J. Dole V.A. At the same time, they named the exercise recreation area that same name on the Air Force Base, which is where I grew up because my dad was in the military there. We absolutely do. We were very honored to have him visit us right before he passed away, unfortunately. But we have different medical center directors. Sometimes they call us the Dole V.A., the Robert J. Dole V.A. It varies. But regardless, that bottom line is his mission, that our veterans deserve that exceptional care, and how privileged and honored are we to get to be a part of that. I think about my dad who's gone to Iraq and Afghanistan and Kuwait, and my mom who's behind with me and my brother as disastrous teenagers. And gosh, what an honor to be able to serve them in the way that they served me, and so that my kids get to grow up and they get to choose whatever religion, whatever life they want to live, because people like him and members in this room chose to be so much braver than I ever could be. And so that is the bottom line of our mission. Even when we have cantankerous veterans who are frustrated or whatever, just like we all have in our moments, myself included, that's okay. They get to be that way. They've earned that. And we continue to share that mission at every new employee orientation, every decision we make. Quality is the bottom line. We are the servants. We aren't the recipients. We are here to serve, and we're super honored to be able to do that. Thank you. Thanks